Well, obviously you've all quietened down, which must mean we're about to start. So fantastic. I'm just going to start with a bit of safety briefing. There's not expected to be a fire alarm, but if you do hear a fire alarm, it's a continuous two-toned alarm. Please follow the fire exit instructions, which are the green illuminated signs. Please don't use the lifts. You should assemble in Mickey Lane. I don't know where that is, but I'm assuming somebody will show us. And can I please remind everybody, please, to switch off your mobiles so that we are not disturbed. So welcome everybody in the room and online to this very exciting event. My name's Marian Knight. I'm Director of the National Perinatal Epidemiology Unit here in Oxford, where Oliver's worked since 2013. He'll fact check me at the end. And on behalf of myself and Professor Krina Zondervan, who's our head of department, I'd like to welcome you to this evening's celebration and inaugural lecture for Oliver. I hope that's where you're expecting to be and that you're all in the right place. I'd like to start with a few very special welcome greetings to all of us friends and family who've been able to join us. So Cece, Luna and Kai, obviously here in the room. I understand we have Guillermo, Alicia, Elena, Robert and family and Katya and family. Welcome to you all. And online we've got Maria and Guillermo, Oliver's mum and dad, Dunia, Maria and their families, and Christina as well. So thank you all. Thank you for bringing the Spanish weather with you, sort of, and welcome. And before I forget, I'd just like to say on behalf of myself and Oliver, very special thanks to Naseem for helping so much with all of the organisation for this evening's event. So please do give just a bit of thank you for Naseem. So I was particularly honoured to be asked by Oliver to introduce his lecture today, because it's not often at a university with a more than 900-year history that one gets to introduce a first. And Oliver is a true first for the university, the first ever person from the Canary Islands to become a professor at Oxford, an achievement that requires a round of applause in itself. And I'm sure one of which his family, his parents are. So I'm sure Oliver will fill in the gaps for us in a lot more detail, but he began his career here in the university in 2002 when he joined the Health Economics Research Centre as a researcher. He went on to complete his DPhil in 2010, and I'm absolutely delighted that he chose to join us in the NPU in 2013, since which he's built up a thriving health economics team, no doubt several of whom are in the room, you can wave. He's diversified from clinical trials to methodological work on measuring and valuing health for healthcare decision making that affects newborns, toddlers and children, as well as making an important contribution to the work of the NIHR Policy Research Unit in maternal and neonatal health and care. Since joining us, Oliver's been awarded more than £50 million in research grants as either chief investigator or lead health economist. He's published more than 100 research papers, including in leading journals such as The Lancet, BMJ and JAMA, including BMJ Research Paper of the Year in 2020. He's internationally recognised for his expertise in economic evaluations, particularly in assessing the cost effectiveness of healthcare technologies, as well as for his valuation work. And his work has been widely cited. It's more, as I say to everybody, it's much more important for your work to be used than for it to be published. And it's fantastic that it's been used by the World Health Organization, the National Institute for Health and Care Excellence, and health departments around the world. I could go on for a long time, but I'm sure you're keen to hear from Oliver himself. However, before I hand the stage over, I thought you might like to hear some comments from Oliver's colleagues, who I asked for some golden nuggets about Oliver. And huge thanks to Ramon for collating these for me. They will remain nameless, but Oliver, I will leave you to recognise who they're from. So, quote number 1. What has always struck me about Oliver is his combination of intellectual curiosity and genuine warmth. For Oliver, learning seems less like a professional necessity and more like a personal hobby for him, pursued through books, courses, conversations, and an endless curiosity about how things work and how they might be improved. One of my favourites. Many of us know him not only as a colleague, but also as a photographer, whose portraits proudly appear on researchers' websites, a talented salsa dancer, a naturally funny companion who's never far from a joke or a laugh, a cool dad, a devoted barbecue host, provided nobody turns up with fish. And for some, an enthusiastic evangelist for T25, X50, or whichever home workout program has most recently captured his imagination. He has never lost the openness, curiosity, and generosity that make people want to work from him, learn from him, and spend time with him. When Oliver was a course coordinator for Herc's 3-day residential course in the winter of 2015, there was a virulent bug circulating, which he avoided, but badly affected all the other teachers on the course. So it turned into a one-man show, with Oliver teaching all of the modules and entertaining the 30 or so delegates as host in the evenings. He was rewarded with a bottle of his favourite rum for his supreme effort, which went above and beyond. And at a wedding in Greece, Oliver navigated the communication with the locals and Greek culture better than his Greek Oxford colleagues. Oliver has a real talent for explaining complex ideas in a way that everyone can understand. We'll test him on that later this evening. He always seems to spot something the rest of us have missed and find just one more thing to improve in a piece of work that everyone thought was already finished. Two reflections to sort of summarize some of that. I didn't ask whether I could say who this was from, but you'll guess anyway. When I joined NPU, Oliver went over and beyond in including me in everything. He introduced me to all staff, colleagues, PIs, and senior members of NPU as the co-lead of his team and his equal. Oliver will never know how appreciative of that I was and am. Not covered by the comments from others is, despite Oliver's attention to detail and eagerness to understand how everything works, he's also very pragmatic, finding solutions to everything and not overcomplicating things when they do not need to be complicated. And finally, one that I'm going to read out in full. In September of this year, I will have known Oliver as a work colleague and a friend for 23 years. Do you know who it is yet? No. We joined the Health Economics Research Centre here in Oxford at around the same time, with me supervising a newly graduated Oliver. Okay. Very quickly, it became obvious that Oliver was an exceptional and dedicated researcher. One day, we might be unsure as to the best way to analyse a data set, and the next day, Oliver would appear in the office with a complete plan of action, having read everything there was to read on the subject the night before. I was always astounded how he managed to keep abreast of all the latest developments in health economics, while also having a vibrant social life, parties, dinners, sports. He once convinced me to join salsa dancing classes, which after being spun around vigorously made me feel quite dizzy. He, on the other hand, was a pro. Oliver is also well known for his love of technology and his eagerness that the rest of the NPU health economics team embrace it too. Meetings can last quite a bit longer than expected when Oliver is present, as he can talk quite excitedly about the functions that an AI agent might be able to perform for us, or how we could use various programs to further streamline our work processes. He always has various machines buzzing away around the office, and last year he introduced breakfast meetings so that we could all learn our software. I don't think we were very good students, but he always persevered. Fast forward to today, and Oliver is now my boss. I don't think it was ever in doubt that he would excel in his academic career, and the whole team were thrilled to hear he'd been awarded the title of professor. Oliver is that rare mix of a brilliant academic researcher and a very genuine people person. And together these qualities make him a very successful team leader. He's built a small but close-knit health economics team who I know will agree with me that we're both privileged and lucky to work under his direction. Many congratulations, Oliver, from all of us. And with that, Oliver, I will hand over to you. I hope I've embarrassed you suitably. Please join me, everyone, in welcoming Oliver for his inaugural.
Thank you very much, everyone, for being here. It's great. I mean, it's fantastic to have my family, friends, colleagues. This means a lot to me. People, my family online. I couldn't be happier. I think I recognize the quotes and I sort of know where some of them were coming from. I'm not looking at anyone, but this is nerve-wracking. I have to be honest. And because when I was preparing the story for today and the slides, I have to explain my family what we were going to do on the event and what it entailed. And the comment that was coming all the time is, we have to listen to you for a whole hour. So now I have the task of obviously make sure that I sort of do a good job and, you know, do my inaugural lecture to a standard for Oxford, but also keep my family entertained at the same time. So I don't know how that is going to go. So as Marian suggested, I will speak about a little bit sort of my upbringing and where I'm coming from and where I grew up. But my presentation today is a little bit of a reflection. I'm going to be discussing part of my research. I'm definitely going to be talking about highlights and things that I have learned over time. But I wanted this to be a reflection for me as well of over the 25 years that I've been at Oxford, what it has worked for me, what it hasn't, and how I see things that could be developed better for my team, for obviously MPU and the department sort of moving forward. So it's more also for you to be here and see whether I can do a good job or not, but also to see a sort of a reflection of where we're going to move forward. So in a style like all the similar inaugural lectures, I'm going to talk a little bit about myself. And I grew up, and I'm from the Canaries, as Marian suggested. As you can see here, you cannot see here, because in the Canaries, you need to point out where they are. So they are around there. And more specifically, we are located towards the south of Morocco and the north of Western Sahara. Although many people, particularly the tourists who just arrived there, have no idea where they are. But at least this is exactly where we are located. I am from an island called Gran Canaria, and I grew up sort of close to the city in Las Palmas. And the Canary Islands are very famous because it's a really popular touristic destination. And I'm quite sure that many people in the room, if I have to put a number, I would say like 30–35% of people in this room probably have been in the Canaries at some point. And here you got two spots of two places of favorite people in my family. So we've got this one here is the favorite place for Sisi, my wife. Are you okay, love? Yeah, no worries. We can wait. I can wait. I have all the time of the world. They are not going anywhere. They are not going anywhere until I finish. So, you okay? Good. So here is Sisi's favorite place. It's called Amadores. It's really nice. It's this sort of location. It's quite safe for the children. But I like Maspalomas a lot. I like open sea. It's so quite, I can have long walks. And we have this debate constantly at home about where we are going, to spend that day. Goes without saying, I haven't been in Maspalomas for more than, I don't know, since I've met Sisi. And although this looks, really, really nice, I wasn't born anywhere closer to these places. I was born in. Is it all right? Yeah. I see. What about him?
That's fine.
Great. So I wasn't born near to any of these places. I was born in a place called La Paterna, which is a neighborhood in the outskirts of Gran Canaria. And it has around 0.35 kilometers square. So it means that it's very small and you have a lot of people. And a recent report that I managed to get by the local university and the city council sort of targeted and put the label. It's a vulnerable neighborhood. It has a high avoidable mortality and morbidity. There's a lot of problem with obesity, cardiovascular disease, and suicide. And it's considered sort of poor socioeconomic status in terms of housing and employment and income. And obviously, I left a long time ago, but I can see that this is pretty much what I remember from when I grew up. So it was a place where, given those characteristics, you had, and it shared the characteristics of vulnerable neighborhoods. There was a lot of bullying. There was, was not personally in my family, but I saw very close the impact of drug addiction and alcohol. I can say, and not the type of drugs that rich people get, the ones that really destroy families. And I saw that really close in many of my neighbors. And you learn how to live with that, but you realize that that's a sort of a difficult environment that you want for your children. But I always sort of remember where I grew up and I came from. And if I can show you here, obviously not for the people who are online, but we used to live in, it was that one, it was this one here. Yeah, I do remember, it was sort of alone, but it was that one there. I mean, I definitely remember. So the idea that a child from my neighborhood could one day become a professor at Oxford seems so far-fetched that most people would have dismissed it as a pure fantasy at the time. So the fact that I'm here today, I shouldn't really be here today by the odds that are happening. So a mix and a combination, as I will show you, of having a strong family and values, luck, I guess at some point common sense in the choices that I was making. So it led me to actually be here today. And also the fact that I really like the city and I like the university. And this is where things are going to be, I guess, interesting for all of you. So although I was, obviously, that was the surroundings, the La Materna, the situation, that was, our surroundings. But, so I had I had 3 siblings and my parents, and I was really lucky to, I was born in a family who had a strong, both father and mother's figure. So I had a really strong mom she's been working her whole life since she was very young, because she really wanted to be independent. She didn't like the idea to depend on anyone. And I think that sort of inspired us all, and in particular inspired us my sort of, obviously all our children, but also my dad. I think my dad is he should be super proud because of my mom. There is one thing that at home that we were taught. The first one is food is important. Obviously, you have to eat. The food is that you have to eat. And those who know me, they know that if you invite me and feed me well, you've got a friend, and that friend is going to stay forever. And then the other one is that they couldn't go to university. So they had this sort of recurrent thought that they wanted to send the children to university, and they worked hard to send the 4 of us to university, and they had to work hard for that. It was not easy. I mean, we know the resources were stretched. They have to make a lot of sacrifices for that. Until obviously that stays with you, not when you're young. When you're young, you don't really appreciate that, but over time, you realize of the sacrifices that your parents make in order for you to be where you are. And it was to a point that this is an old photo now, but it's around 10 years ago, where the local university had something like the university for the 3rd age, and they managed to go to university. They had a degree, and I think we were all quite happy that happened. What we've got here, I don't know whether you will be able to see it. What we have here is my university application, which on doing the presentation, I just went back and looked at documents. And what I wanted to show is that this is you had to make like an order. It was like choosing a school for your children. You choose school A, B, C, and then here you choose the degrees that you wanted to do. I wanted to study medicine. I didn't get the marks, and obviously then there was a way I could have done it. But anyway, for some reason, and I do not remember the reason why I put economics as the first choice. I didn't. I hadn't been taught economics ever in high school. I always went to public school until only 4 years, and my parents had to make an amazing effort to send my younger sister and me to a private school for 4 years just to get outside of La Paterna type of environment, because obviously they wanted to keep a little bit more control of who we were, handling with, and having conversations and enjoying time and things like that. So except that, we always went to public school and higher education. Obviously, the university did the same. I never had economics. I don't remember why I chose economics as the first choice. I still don't know. My mom made some suggestions when I asked her last week or a couple of weeks ago, but those suggestions seems more far-fetched than actually being here today. So I don't think that none of them. That's why I'm not mentioning. But what you can see, they're in Spanish, but you've got obviously economics, business. I wanted to be a teacher in special education needs, but there was a lot about health. So it wasn't health economics, but I think there was some ingredients there for a mix that I might actually, there was something there in the mix for me to be a health economist today. So I went to the local university. I went to the University of Las Palmas, and the department is called FIT, which I think is a fantastic name for a clinical department of a lower limb, but not for an economics one. I have told them that, and yeah, anyway. And I was lucky that I had a few teachers who they were either into health economics or they were working in cost-benefit analysis or econometrics, which were subjects that I always enjoyed when I was doing my degree. So with conversations with them, making sure that obviously that what it meant for me to be abroad to study health economics, when I found out that there was something about health economics, there was Professor Lopez Barcalces. He's a really well-known health economist in Spain. We had a lot of conversations. He signed with Ginés de Rus. They signed my reference letter, and I applied to York. And this happened. So I was rejected to go to York. And obviously, I was thinking at that time, why these people, why these people didn't accept me? And I sent an email to what was the course coordinator at the time, is Professor Andrew Jones, and never replied. So I decided I'm going to call him. So I went and I called him. At that time, we didn't have at home. It was really difficult for us to get the line to make a phone call abroad. So I was working in international relations. I was doing photocopies, and I was working with a professor there called Jesus Arteaga. And I sneak into one of the rooms and I call Andrew Jones. I don't remember the conversation with Andrew Jones at all. But I can see that either way, it was two ways. The first one is somehow he knew that I was from La Paterna. He wanted to make sure that maybe I knew someone who could do real damage or something like that. So that was the first one. Or that he saw something in the conversation that we had together. And he gave me a chance. He send me the transcript of what you have done so far, and we'll see. And I sent him, I wrote this email to him, and obviously explained it to him. I'm almost finished. I only got a few subjects to finish. I'm working hard. And there you go. And I was pleased to, I received my offer to go to York to study health economics. And it should have ended there. However, in England, like in many nations in the UK, you have to speak English, communicate in English, and write English. And I had been studying, but not hard enough, and I didn't make the cut. So I failed the test the English test. So then I went over with them, having conversations, and I guess now I sort of understand why they allow me, and they gave me they said, okay, you can come not as an MSc position, you pay, you register, you come as a visiting graduate student, and you got until December to get either a 6 in the IELTS or 550 in the TOEFL or 213 in the computer-based. And magically, I went to York as a visiting student, and I was doing the master without a place in the masters. But then, obviously, I did my exams in December, and I got, for both exams, I wanted to make sure that I got it in. So I went and I bought it and I passed. And I was rated as a good user in 2001. And there you go. I finished my MSc, in health economics, and then my journey in the field of health economics had begun. When you study, when you work in any field, and in this case, sort of the one that I was lucky to be sort of involved, there are few people who are important in the decision that you are making. And when I arrived into Oxford, I arrived with, obviously I came to the Health Economics Research Center, I came to do a summer placement and the supervision of Alistair. And I was then working with Alistair for more than 10 years, obviously as a junior. Then I did my PhD as a postdoc. But once I finished my time with sort of with HERC, then I moved into the MPU, and I was really lucky to have two line managers who were being extremely supportive of any single decision I wanted to make in my career and for my team. And that makes a huge difference when you want to have a career. If you've got people who support you in the decisions you want to make, then you end up making better decisions. If I have to think, to be honest, that I think Alistair had the worst of the jobs in the sense that he had to endure, and Oliver, who was quite junior, and had to endure all the things that happen when you are learning. But he gave me the opportunity to learn. First of all, he was curious. He was a curious person. He was a curious man, the same as I am. And he gave me the opportunity to actually explore things and work with things. And if he was wrong, I don't think he got very angry at me. Maybe in a few occasions. I'll tell you later. But he was extremely supportive for me all the time and what I was doing. Then when I arrived in MPU, first with Jenny and then with Marian, then they support me in a different way. They trust me that I could do the job first of all, they trust me that I could do the job independently when I arrived, which was a big if. But they made that call and they trust me. But then they also trust me on the way that I was going to be sort of, behaving at sort of higher standards. And for that, I'm extremely grateful because that meant a lot for me and it still means today. In addition to them, there are a few people and sort of characters that I would like to call it, who they are at the same, we call it at the same level. We learn together, we spend time together, we laughed and we support each other. And these are some people that sometimes you don't know what you have to do as a professor. There's an expectation that you need to know everything. Tough luck, you don't. And you need to rely on other people. And you go, and these are the people who actually helps you to support you. And here we got obviously my team from Oxford, and then I've got my Europol team, and I got Simon coming from the States today, and that means a lot to me, my friend. And so these are people who I can bounce ideas when I'm working with health valuation. We can be honest with each other, and we can move things forward in a way that it makes complete sense. And an anecdote, as you know, there are two people in the room, one called Ramon and the other one called Jose, who you might identify them by Ramon and Jose. However, for I don't know how many years at HERC, the situation was like this. I still don't know why exactly, but yeah, for some people, I mean, they approach Ramon and Jose the other way around. And as Helen mentioned, I mean, Helen and I, we've been working pretty much since day one I arrived here. That's something that I truly value heavily every day. So I know who I have in my team. So my time at HERC, so with those 10 years or so, my first paper was in the BMJ, which I published with Alistair and Helen. And it was about using surgery for low back pain. I was comparing surgery versus non-invasive techniques. Things hasn't moved much since we did the paper. It's still non-invasive technique. It seems to be as simple or probably more cost-effective than surgery. But what I wanted to show with this graph in here is that the work as a health economist involves three things. It's about outcomes, costs, and then cost effectiveness. And these are the bits where I spend at HERC just trying to learn how to make these tables, these graphs, just to understand how to derive these profiles, what it meant, and I learned a lot during that time. Was lucky to work in the ISAT study, which was about subarachnoid hemorrhage for, it was comparing coiling and surgery for subarachnoid hemorrhage. It's a landmark study, has changed clinical practice completely. And we managed to use that data to show that not only it changed outcomes, it actually coiling was a lot better than neurosurgery for patients with subarachnoid hemorrhage, but we shown that it actually bring people back to work earlier. And it's one of those studies who they have followed patients up for more than 10 years. I was lucky to keep the collaboration with HERC ongoing, and we showed that there was a quality difference even after 10 years between the two of them, not only because of survival, but also because of quality of life. Fortunately, one of my friends last year had a subarachnoid hemorrhage, one of my closest friends, and he had a grade 4, which was a huge one. And because of ISA, that sort of knew more or less what was coming. And I'm really pleased that he survived, that he's almost over the first year, and he's listening. And I'm telling him, I don't know whether he's going to be happy to hear this, but I think he's going to back to work quite soon. So, but anyway, that's for him to evaluate. HERC was a time not only to do applied work, but Alistair obviously it was Alistair, primarily Alistair was supervising, but it has Jane, has Philip. It was about methods. And we spent a lot of time working with data and tried to do methodological work to advance what we were doing with economic evaluation. So I did a lot in terms of mapping exercises, which means we have information about some instruments, about quality of life with an instrument A, and you don't have instrument B, and you want to translate instrument A into instrument B, for example. This is widely used by the industry because they only spend money for the things that they think they need, rather than for the things that they need now, rather than for the things they're going to need later. So I did a lot of statistical modeling, a lot of economic metrics in using multinomial logics and discrete, so categorical dependent variables. And my time working with Philip and Alistair, what we wanted to do is we had a competitor who was the Franks model. And that one was it was the simplest model you can get. Really difficult to beat because it was estimating means. And estimating means, it was, OLS, it's a winner. It's a really good one. But we were doing a response mapping, which is instead of trying to predict the score, you try to predict the actual questions from the questionnaire. So you had more information in the end. And I spent these hours just on the computer working with Stata, just trying to make these values that you see here closer to those that you see actually there. Making these two closest to that one there. We never made it. At that time, we didn't do it. And I remember, Alistair and Philip they weren't sad, but definitely they said, okay, we can do sort of better. Years later, we did make it. And we managed to convert the M-logit in a way that it was quite, closer to the OLS. And it was a really widely used mapping algorithm these days. We use that information, we do guidance, which is something that I always try to do and impose in myself. You know how to do something and you have learned, just you need to be able to communicate that so people can actually use it and do better work later on. We did this particular work. In addition to mapping, I have spent a lot of time when I was doing my sort of HEC users training with missing data. I was fascinated that nothing was complete, ever, in any trial that you have. And you have to learn to live with that. And you need to learn how to do a statistical analysis when your data is incomplete. And I did a lot of particular multiple imputation at that time, just to make sure how can we use those techniques in the work we're doing. I did my doctorate using the ISAT study, which is a multinational clinical trial. Did it in Merton, handed it in 2010. I also got married in the grounds of Merton College in 2010 to a woman where I have married in 3 different countries. I'm married to the same woman in 3 different countries. And after a brief postdoc at HERC of a couple of years, I moved to the National Prenatal Epidemiology Unit in 2013, the same date where Luna was born. And I have been there since. And I love it. That's the bottom line. I have obviously got a fantastic team, but the team that we do at the MPU started with the SLT, the support for each other, understanding that everyone, you know what you have to do, you know what your job is, you let people be, then that helps to move, research forward, and it's multidisciplinary, and I'm really proud to be working in a place like this one. With as Marian mentioned, I would say it's not small. We are enough. I think we are enough. When you start getting really big, then you don't have control about the personal sort of interactions that you want to have with your team. And the work that we do sort of follows three different sort of streams of work. We work for the policy research unit, which tends to be sort of really sort of fast, is informing the NHS about specific decisions, and we support with evidence so they can make decisions faster than when you try to demonstrate the value of interventions, which normally requires a trial, it requires a lot of time. And then obviously there's the methodological developments. I'm going to be talking, I'm not going to be, because it wouldn't be fair for you and it wouldn't be fair for me. I don't remember many of all the publications that Mario mentioned at the start, but I'm going to give a few of them. We have completed, as of this week, there was going to be a report tomorrow. There will be a report tomorrow, a maternity investigation report tomorrow, which I recommend that you keep an eye on the media. And as part of that report, my team and I, we have involved in the cost of maternal and neonatal healthcare across different ethnic groups. And inequalities in maternal mortality and neonatal mortality exist. We know that these exist. There is a concern in the NHS, there is a concern in the government. We need to reduce those. And what we have done is a study which just shows that those inequalities that exist cost around £360 million per year to the NHS. And we have written a report, and that we have used that information in that report. It's a simple exercise. It's using aggregate data, using the data you have available. You derive quickly, you provide that information, and it's useful. And that's one of the things that we do in the policy research unit. Another aspect of the work that we do, and I think many people in this room probably are tired already of looking at sort of determining the value of what we talk. And I like the word value. For me, value, it's an important element as an economist. And when I do economic evaluation, what we're trying to do is estimating the opportunity cost of making decisions and making the sort of, you want to make the right decision. And normally it's a simple thing. It's a simple concept. What you would like to do is determine the amount of money, the additional amount of money that you're going to spend in something new, in a new intervention, in a new program. And you want to compare that with the potential additional benefits you're going to receive from that particular amount of money. And using the methodology that we do put together, we determine whether it's value for money or not. And that's the main objective of the economic evaluation of healthcare technologies. We use everyone in the room, conscious or unconsciously, use the concept of value. We are always making trade-off. You are always thinking, okay, if I'm going to spend that amount of money, what is I going to obtain? In our case, it's just a way of getting that sort of in a methodologically and robust way. So working with the CTU, we have been involved in many studies to determine the value of pregnancy and neonatal care interventions. And I wanted to bring here the first sort of reflection that I got when I was doing the talk, which is the maternal and child health relationship and the relationship on the treatment effect. So we conduct randomized controlled trials with interventions that improve pregnancy care or that improve neonatal care. And that means that you're going to do something on the mother or the baby, but that relationship goes in both ways. You cannot separate that relationship. And that means that the impact that you're going to have or effect that you got on a treatment effect on a randomized controlled trial is going to affect both. And that means that as a health economist, it could expand to other members of the family. So that means that when we want to understand the value of a new therapy, we need to think about what are the costs and consequences for the pregnant mother and the baby, but also to extended members of the family. And it means that you need to think about what costs you want to capture, how you want to capture, and that means that you have to have this conversation about how much data you need. And you cannot collect everything. You need to be realistic and pragmatic. And it means that sometimes you have to give up. If you know that something is not going to be a cost driver of an intervention, then it might mean that you don't need to collect that. It underestimates the total cost at the end, because you're not going to have a precise estimate of cost. You don't. But it won't affect your incremental cost, which is what we are after. So that conversation, which is something that I have to normally have with clinicians, have led us to obviously have some examples of high quality work and trials that we have published. Just a few examples here. This is a note where we compare the use of antibiotics, prophylactic antibiotics for the prevention of infection following operative delivery. Extremely significant, very helpful for instrumental delivery. And the economics show that because women who had prophylaxis had less infection, the whole course of resource utilization was lower. We could estimate that, and we could put that in the paper, and the Lancet was happy with that story, because it followed really, it was not only about infection, it was also about what they're consuming, and we didn't observe any difference in quality of life. We're going to come back into that in a second. Another study is the BAM trials, where it's about hypertension disorders in pregnancy. And we conducted this trial, it was 2 trials in one program of work about pregnancies of higher risk of preeclampsia and participants with chronic and gestational hypertension using self-monitoring versus usual care. And we showed that self-monitoring didn't really affect any of the primary outcomes, and it didn't have any impact on resource use, cost, and quality of life. Completely different story than a note. But in here, even the cost, because self-monitoring, there was this concern that where a lot of women were using self-monitoring, and they were concerned that because of the readings that we were receiving, they were coming more to the GPs and it was costing more. That didn't happen. So we were able to show that and put it as well as a paper. When we are talking about a node and BAMP studies, there is this issue of extrapolation, which means that in most cases, the treatment effect extends beyond what you observe in the trial. And this is just to mention that in a node, because we completed, I think it was a 6 weeks follow-up, we knew that there were some women who, we know that perineal wounds are not as severe as cesarean wounds, but there were some women who still had some perineal wounds that we couldn't observe over time. And you can do some simple extrapolation to do that one, and you can just have that on your paper. But something like hypertension, where it affects modifiable risk factors, as you can see here, this is a conceptual model that I have been working with the team. And we think that we do have a model like this one that allows you to extrapolate from your treatment effect when you conduct an RCT in hypertensive disorders. But the type of extrapolation that we are doing could be better. We know that there are risk equations that are based in adults, and they don't work really well when we use it in maternal. We think that this is an area where there's a lot of potential, and we are working with a collaboration with primary care to make that possible. I showed you before that in some of the trials that we have done, the EQ5D didn't show anything. The EQ5D is a quality of life instrument recommended by NICE, widely used all around the world. And as in this graph, I like this graph because this is the EQ5D, where you've got the 5 domains, so it's mobility, self-care, usual activity, pain and discomfort, and anxiety and depression. And you got the presenter reporting problems on those domains. And you will see it mimics quite well what happened in pregnancy. It definitely gets worse over time. And once the baby is born, then the quality of life sort of diminishes and deteriorates. And that's what it's meant to do. So the instrument is definitely capturing the impact of pregnancy. The problem is treatment effect. Is how can we estimate treatment effect when the instrument is already competing with with pregnancy. So see how to disentangle these two issues, and that's something that we haven't come across, and we are working on that as well. We do have a whole set of instruments that allow us to measure health-related quality of life across the life course. So we've got now, and I've been involved in the development of some of these in here, like the adapted. I've been obviously keeping an eye really close to my colleagues in the Europol group who has developed quality of life instruments for birth to 2 years old. And I'm pleased to say that we now have, studies recruiting in our with our unit who are using these instruments. So that's another element where you develop methodology, you know that it's been developed, and then you can use it in your applied studies. But one of the things I've been wondering is quality of life. It is important because health economists, we have a metric that we use that we call QALYs, where we use to compare things. And I'll come back to this at the end of my talk. But I have the feeling that it is not only about quality of life. Maybe we need to think a little bit outside the box when we talk about pregnancy and neonatal care. Maybe we can think about health-related quality of life is not, I wouldn't say it's not enough, but there are wider aspects of health like capabilities and well-being. And these are potential instruments that we might want to start to explore. And the reason I'm mentioning this is because my experience working with clinicians is, although everyone got at best the interest of the patient and the families, there is this resistance to sometimes collect data. And without collecting the data, you will not know. And I think there is a room here for economists to not suggest that we move away from the quality paradigm and we start maximizing something that is not quality-based. But I'm saying that in our story, something like capabilities of well-being are important. And for doing that, you need good collaborations, and good collaborations matter. You need to get good collaborators who allows you to at least have a voice in the room. And here are some of my collaborators. And here goes my next reflection, which is understanding your role as a health economist when collaborating in medical research. And I recently found out, I don't know how this is going to go very well. So I recently found out that in chess, you use each of the pieces got values. And those values, they use it to think about the strategy and the game that they have at hand. They are not used to create a score or anything at the end, but you use it like that. And I was thinking that my job, my role as a health economist when I'm working is similar to a chess game, where you think there is one player who wants to have a successful program of work or a successful research, and this is an invisible player who's going to do everything they can to beat you. And your role is to make sure that your story for the research is to move across which piece of the chess you are. And you can only do that with a strategy. That means that you need to learn, you need to know how to be quite strategic when you're doing medical research. That means that there are times that your story might be, I don't consider myself a pawn anymore, but I think probably a knight of a bishop these days. So at least.
I can't believe knight points.
But I think the issue is how you move in the story. So, and by the way, the king is the principal investigator who has an infinite value. So you, knight, I think you probably are right. So he's the principal investigator. It means that you need the principal investigator to conduct this work. So your job is to make sure that you know which piece you are and how you move in the research. To conclude my talk, I would like to talk a little bit about my sort of methodological work. And I have an interest in valuing health in the sort of economic evaluation. And in particular, we've got health economists, we have something called the QALY model, which essentially means that because it has the theoretical and mathematical characteristics that we need to include it in our analysis, the model is very simple. We believe that patients follow up sort of health states during the condition. And in these health states, they spend some time, and the time that they spend in a particular health state it means something for these patients or for other group of patients. So there is like a weight. So a QALY is simply the amount of time that you are in a health state multiplied by this weight. What this weight is, normally we measure with a preference because we think that the more QALYs you have, the more desirable they are. And we equate, desirable with preferences. And we collect preferences from populations to understand how to estimate these QALYs. And that's what my methodological work does. In order to do that, when I conduct evaluation exercises for adults, the situation is very, I wouldn't say simple, but it's streamlined. I know what I have to do because there's guidance out there about how do I need to estimate these preferences to estimate QALYs. And essentially have these 5 normative considerations, starting for what is to be valued, which is QALY. The descriptive system that you use is the EQ5D, in this case 5 level or 3 level. And you can collect information from the general public or patients. And when the participant is completing the elicitation tasks, they do it from their own health, and obviously the preference elicitation method that they use is quite standard. My methodological interest, the only thing that I know is that we want to estimate QALYs, but I have no guidance about any of these other normative considerations. And I conduct quite a lot of work trying to disentangle how to inform some of the gaps in that particular chart, in the particular boxes. And this is something that we just published this year in collaboration with some colleagues, make sure that we can make sure how we can conduct these exercises. So I want to come back a little bit just to the end, to these sort of 2 possible choices here. Now I have done a sort of what we call an unlabeled sort of discrete choice. We call it discrete choice experiments. So we've got destination A, destination B. If I present these 2 scenarios to enough number of people, people will start choosing between them, and using mathematical model, I can relate the characteristics of these 2 destinations, and I know the value that people place to open C, close C, having restaurants, so on and so forth. Widely used in marketing. We also use it in CISO to estimate an algorithm that allows us to determine what was a successful outcome for a child with a surgical condition. What you can see here is the value for different groups that we ask. Obviously, compared to survival, quality of life and survival were really, really important for most of the population. I normally do the same, but I do things like that. Like where I present them is this type of exercises for maybe adults and adolescents. They read the statement and then they tell me whether they prefer A or B. And if I do that with enough people, enough time, I can sort of get a sense of the value that they place to different aspects of health. And what we have found out, and I'm proud to say that we were one of the first teams in showing this, is that at least for the EQ5, in terms of the EQ5D Y3L states, the preferences between adolescents and adults are different. We have different preferences. And I've always been an advocate of having preferences from adolescents used in decision making, because they are going to be the ones who are suffering the health states. But in order to, that's what I believe, and I believe in the context of research might not be extremely robust, but I've done many exercises where I have done discrete choice experiments with adolescents, and we've shown that the health preferences are different. But also, one of the things is that they tend to have a slightly more inconsistent preferences when you are completing these exercises. When you engage with them, they don't have that clear preferences, as you can see. Here, this is, I'm only suggesting that this is what I would suggest is a clear preference. This is A or B, very dispersed, nothing in the middle. In adolescents, you see a little bit more sort of random behavior. And here, my colleague John Nazari and Simon has actually, reported something very similar in the US when they did the value set. With this information, what I'm doing currently is I'm leading the EQ5D Y3 level value evaluation exercise, where we are estimating a value set that will allow us to translate these preferences into a value set that will allow us to calculate quality so it can be used in decision making. So for the last couple of slides, and thank you very much. I honestly really appreciate your time and being here today. I've got two more slides. And the last one, or almost close to last. Firstly, I said before that collaborators matter, but family matters more, because the other ones, because I got here 3 members of the family that are a lot of work. But I know that I'm a lot of work as well. So I think it's a nice combination for us. So thank you very much for your support over the years. Thank you very much for being there. I love you, the three of you, equally. No chances there. And my last slide, I wanted to show how this is an experiment that I did on a Sunday morning. So I apologize that I'm on my pajamas, but I think it will summarize quite well where sort of why my methodological work is so difficult. And with this one, thank you very much, and thanks for being here today.
No, pero tienes que elegir uno. ¿Cuál de los dos quieres? Este. Pero mira. Pero tienes que... ¿Tú quieres este? ¿O este? ¿O cuál quieres? Tienes que elegir... Espérate. No, pero tienes que elegir uno. Ay, tienes que elegir...